A very good evening. Thank you for the opportunity to speak on the stage. Um, my talk would not be on the genetic disorders per se. It would be basically more on the oncogenomics. A comprehensive tumor genomic profiling is what I'd be talking about. Utilities and challenges, especially for a formalin-fixed paraffin-embedded tissue, not the hematolymphoid disorders. So this is the overview of my talk. Advent of precision medicine, tumor profiling. What is tumor profiling and what is a comprehensive genomic tumor profiling? A TrueSight Oncology 500 assay, utilities, challenges, and summary and way forward. So this is how traditionally a tumor is treated. Initially, it was surgery, then chemotherapy, radiotherapy, and hormonal therapy. These are the various different lines of chemotherapy we used to use: alkylating agents, antimetabolites, topoisomerase inhibitors, and others. However, so we are moving towards targeted therapy and immunotherapy. Just trying to understand what tumor profiling is when a lab method detects the presence of certain genes, proteins, or any other molecules in a sample of blood or tumor tissue. It is tumor profiling, and it gives information about the molecular change in a tumor. It is used to help plan treatment and also for prognosis. Tumor biomarkers obviously, tell you the molecular signature of a tumor, and each patient's molecular signature is different. And so that's the reason why we go in for precision medicine, which is the era now. And when a biomarker is paired with a treatment, it is also called as the companion diagnostic test. Various targeted therapies that we have in the form of EGFR inhibitors, CDK inhibitors, the anti-CTLA monoclonal antibodies, and so on and so forth. PARP inhibitors and VEGF inhibitors especially. This is the era of precision medicine, wherein we have targeted therapies for each and every target that we're able to find in a tumor. On the right, if you see, that's the example of a non-small cell lung carcinoma. Depending on the target in the form of EGFR, NTRK, ALK, or BRAF, you have specific targeted therapies for them. And immunotherapy is where you use when there are pan-cancer markers like a tumor mutation burden if it's high or a microsatellite instability is high. When there's no alterations are found, then a standard chemotherapy is used. These are the various enumerated targeted therapies available both for hematolymphoid as well as solid tumors, which are in use now. There's a growing list of biomarkers for each and every organ in the body. And these biomarkers are being approved, every day, especially for solid tumors, the pan-cancer markers, as I was mentioning earlier, the tumor mutation burden, the MSI status, as well as the NTRK rearrangements. The new kid on the block, HRAS mutation for head and neck squamous cell carcinoma, approved last month by the MD Anderson. G12S was the target. And the cohorts which received tipifarnib had a better improvement in overall survival compared to the ones who did not get this therapy. However, there's a caution wherein a co-mutation pattern of HRAS mutant could be distinct, and obviously the co-mutations do provide us insight into various therapeutic combination strategies. Conventionally, an FFPE is subjected to different testing methodologies in the form of PCR, IHC to look at whether if it's to find out a definite diagnosis in the form of say TTF1 or napsin for a non-small cell lung carcinoma, then FISH, say for rearrangements in the form of ALK, cross, RET, a small NGS panel which would look at few targets, and an IHC2 possibly looking at PDL1 status. So all this wastes a lot of tissue, and when tissue is an issue, obviously with the growing number of biomarkers that we have and the pan-cancer biomarkers which are available, we need a single assay which could detect all of these molecular signatures. A single gene testing was previously done in the form of reflex. So if I did not get an EGFR mutation, I'd go in for an ALK. And I did not get an ALK, so for a ROS, and so on and so forth. And it requires an algorithm wherein the tissue is, an issue as usual. And with expanding oncogenic driver alterations, it is not a sustained algorithm to be used for patients. A small hotspot NGS panel can be used, but it's found by various studies that they can miss druggable mutations. So a comprehensive genomic profiling obviously looks at more actionable variants and small panels, and obviously single gene algorithms. So what is a comprehensive genomic profiling? When there is a simultaneous detection of all classes of genetic alterations in the form of mutations, insertions, small indels, copy number variations, gene fusions or rearrangements, tumor mutation burden, microsatellite instability, all of these in one assay, then that's a comprehensive tumor genomic profiling that we're looking at. What are the time points at which a comprehensive genomic profiling is done? Is it at diagnosis, at the first relapse, or at the time of progression? What stage of the disease? These are the points to ponder about and to discuss. So one test, one workflow, and one report is much more easier for a comprehensive genomic profiling, wherein we can understand more of druggable mutations than what were possible uh, uh, with an algorithm. So these are the various studies, if you see from 2016, 17, and 19, and the percent of actionable variants which were found using these, using the comprehensive genomic profiling as compared to single gene or small NGS panels. Various various comprehensive genomic profiling options available in the form of CARES, Foundation One, Oncomine, and today I'm going to talk about the TrueSight Oncology 500 assay. Um, More than 1 MB of DNA is what is required for you to talk about what the tumor mutation burden is. And this assay covers about 1.94 MB. 523 genes are interrogated for SNVs, indels, as well as for TMB analysis. 59 copy number variants, for in the form of rearrange copy number variants are seen. 55 RNA fusion genes are seen, are interrogated. The input would be an FFP, DNA, and RNA. However, a ctDNA liquid biopsy assay is also available. There is a homologous recombination deficiency algorithm also available along with this kit. There are various alterations in various different organs wherein a tumor is formed, and the pan-cancer markers are also interrogated in this assay. Tumor mutation burden, a cutoff of 10 mutations per megabase is what is a cutoff for targeted therapy. Various studies, especially the Foundation Medicine, also has a concordance with this particular assay. If you see the graph, and it also is concordant with the whole exome sequencing, wherein 137 mutations per exome is what is seen as what is regarded as the cutoff. The reporter operating characteristic curve covers the TSO 500 assay along with Foundation One and whole exome sequencing. Various studies about this assay which have used and have found relevance to targeted therapy of this assay. This is how a clinical reporting of a comprehensive genomic assay is done. On the left, if you see the sample processing and the sequencing happens in a wet lab. And in the wet lab, the DNA is extracted, QC checked, libraries prepared based on different pools of primers that we want to amplify certain genes or target regions, and then laid down against the targets, and the assembly is done. The variant calling, data visualization, and variant annotation, that's the dry lab part. And that is where we understand which variants are important towards the phenotype, or rather the tumor in question. The clinical interpretation and classification is done according to the AMP-ASCO CAB guidelines. Variant of strong clinical significance, which is variant 1. The level of evidence can be A or B. A being the FDA-approved therapy is available for this particular tumor type. And for B, it is the consensus is based on well-powered studies in the patient's tumor type. For the class 2, C would be the level of evidence wherein FDA approved therapy or practice guidelines is available in other tumor types. And for level D, it is the case reports of preclinical studies. Variant 3, variant of uncertain significance, and the likely or the likely benign variants are not reported. What are the advantages of a comprehensive genomic profiling? So 523 genes covering all these fully coding regions result in tumor mutation burden estimation, single nucleotide variants, as well as small indels. So these genes, they obviously are covered in major clinical oncology guidelines and many of these clinical trials. We require a dedicated primary analysis, secondary analysis, as well as a variant interpretation software for this. We obviously require the unique molecular identifiers to understand if there are any PCR duplicates that we need to remove. Fusion identification is done at the LOD of 0.5% for the genes included in the assay. And it covers 100% interact fusions, which are more than 100 at this point of time. What is the utility of a chromosome of a comprehensive genomic profiling? Especially when these are the points where a comprehensive genomic profiling would obviously give you more information than a small gene panel. Carcinoma of unknown primary, when there are tumor agnostic target therapies available, BRAF, you're present in hairy cell leukemia versus your non-small cell lung carcinoma or a melanoma. Small NGS panel when they are inconclusive and there are no pathogenic variants or mutations detected in a patient's tumor. When the HRR and the HRD score are required, especially for PARP inhibitors in the form of BRCA, the breast cancer, ovarian cancer, prostate, as well as in pancreas. And various other clinical trials obviously would give you more druggable targets than present in a small NGS panel. These are the points that I was talking to before, what stage of the disease and what time points are required. However, the challenges are for a comprehensive genomic profiling, both in the lab as well as in the clinics. In the lab, the most important challenges are faced in the form of pre-analytical variables. Every sample poses a unique challenge to you, and the understanding of the challenges is extremely essential to be able to tackle them and to troubleshoot them at every point. An FFP, DNA, or RNA is not an ideal nucleic acid to be sequenced. However, in the Indian scenario, there's prolonged fixation, delayed fixation, or acidic pH obviously would not give you good results. A, a QC check at every step of the wet lab is extremely important. For these tissues which have been prolongedly fixed or fixed in delayed, we do a UDG treatment, which is important for the deamination. And the established tumor cellularity cutoff is extremely important. 10% tumor cellularity is what is used for a small NGS panel looking at small variants. However, for a comprehensive genomic profiling, somewhere between 20 to 30% tumor cellularity is what is recommended. And the cartoon tells you that whichever nucleic acid that you've extracted, if it's good, then your results are going to be good, or vice versa. The challenges on the clinical side, say this study on a comprehensive genomic profiling assay 2 years, before 2019, looked at it was a small study, 200 patients. However, they found only 4 patients who had clinical benefit from a comprehensive genomic profiling. So we face these challenges, the number of patients undergoing the comprehensive genomic profiling, especially in India, where cost is an issue. This is the way forward, wherein we're looking at precision public health. An individual's tumor, if you're looking at the phenotype, what is the morphology, genomics, transcriptomics in the form of what RNA rearrangements are present, exposomics, what are the exposures that say this is something simultaneous, like similar to what is epigenomics, and then the metabolomics, proteomics, and the microbiomics of that particular tumor. So if you look at one individual and if you're looking at a population together, then we can achieve a precision public health, comprehensive profile. I would like to end by saying that a comprehensive genomic profiling unlocks the unknown, DNA fusions, DNA mutations, indels, copy number variants, tumor mutation burden, microsatellite instability for the DNA, and on the RNA fusions as well as splice site mutations. So thanks for your time.